This is our critique of the assessment of the economic impact of Belimumab for the treatment of systemic lupus erythematosus in the Italian setting, a cost-effectiveness analysis.
My name is Cody. I'm going to be talking about the first few slides here. First thing, whenever we analyze an article, we want to look at the title, and we want to ask ourselves, is the title appropriate? So the study lists the type of analysis used in the title, which is the cost-effectiveness analysis. It mentions the disease state as lupus. It also mentions the setting, which is in Italy. And it also mentions the treatment that is being analyzed, the actual intervention, which is Belimumab. But it does not mention the comparator in the title itself. We will also want to look at the objective. Is it clearly stated? So overall, the objective was stated as evaluating the cost-effectiveness of Belimumab. That is clearly stated. It does not mention what it is being compared to, and it does not mention how it is measuring cost-effectiveness. What kind of units are they using? Is it creatinine clearance, quality adjusted life here? They don't mention that. It's only later on that we realize that it is the cost per life year gain as ICER and cost per quality adjusted life year as ICUR. Those are the objectives. We will also wonder the alternatives. Are they appropriate for this kind of comparison? The alternative listed was the standard of care. This was defined as glucocorticoids and various immunosuppressants. We pulled up some other guidelines that deal with lupus, and we determined that this is appropriate. These are appropriate medications that it should be compared to. Of note, some medications they excluded, and that's perfectly fine because those medications were more for like refractory lupus or lupus or medications that don't have actual FDA approval. So in terms of describing the alternatives, we want to know like doses, the scheduling and stuff like that, and we are wondering if they actually took time to describe that. So it did list all the medications as we went over in the standard of care, and it gave the dose for the corticosteroids, but it did not mention doses or duration of treatments for the other medications. It also did not mention the route of administration for those medications, which is something that we would want to know.
Next, we're looking at the perspective. The perspective of the article that we found was that it is a societal perspective. They looked at the NHS perspective, which includes the direct medical costs of SLE related to adult patients with active disease, autoantibody positive, with a high degree of disease activity, despite using the Euro 2011 cost data. They also looked at the utility scores by measuring the loss of productivity in young women of childbearing age. And next, we'll look at the type of study. The type of study that we found is that this article is a cost-effectiveness analysis. They state that they followed a model which was originally developed for UK, but they adapted it to the Italian setting. This study is correctly identified as a cost-effective analysis because the costs, which was measured in euros, and relevant clinical outcomes, which measured the survival of life years, organ damage, disease severity, glucocorticoid use, and glucocorticoid use. It seems that the protocol-driven costs are excluded from the study, but this is difficult to assess as the data comes from models derived from clinical trials. It is not explicitly stated in the paper. The outcomes may vary when patients are not being monitored. The paper mentioned that the costs attributed to monitoring are included, and the paper also included utility values, so this could be more specifically identified as a cost-utility analysis. And these utility values were based on the EQ5D assessments in the Belimumab clinical trials. And next, we are looking at the relevant costs. Were all the important relevant costs included? The authors of the article included 4 relevant costs. They are the short-term disease activity costs, Belimumab costs, organ damage costs, and indirect costs. With a short-term disease, they measured the disease activity using a Selena-Slidai scale measurement. And this basically measures the disease activity at the time of the visit or in the previous 10 days, which corresponds to the disease activity. With this measurement, they estimated that per patient for every year, it would cost 512.94 pounds. Next, the Belimumab cost that they acquired was the acquisition costs, and it was found to be 131.96 pounds for the 120 milligram vial and 439.88 pounds for the 400 milligram vial. For the organ damage costs, they determined the basis of they used the base of a Systemic Lupus International Collaborating Clinic data to create to generate a weighted average of the costs because the Italian data was missing. And lastly, for the indirect costs, they estimated the increase in hours missed from work for every unit of Selena Sledai.
So next we're going to talk about the relevant outcomes. So in this study, clinical outcomes were included as well as both life years gained and QALYs. And these were assessed over a 6-year period since this is the limit of data for Belimumab for FDA approval at the time of the study. In a sensitivity analysis, they did extend this to 10 years, which is appropriate because we would expect patients to, in the future, be able to continue this medication. So extrapolated Selena Sledai scores and glucocorticoid use from the BLISS trials are measured, and these, in addition to patient characteristics, are used to estimate long-term outcomes of organ damage and mortality, which is relevant and important as lupus can cause various types of organ damage. Side effects of treatment were not measured or addressed in this study, and so this is something where the authors could improve on measuring relevant outcomes. And quality of life was measured using the EQ-5D questionnaire of the BLISS trial patients. So in this study, they also used a 3% discount rate. And so since money and health outcomes are worth now more than in the future, discounting is used instead of adjustment because we're trying to predict future outcomes. So the use of a 3% rate is appropriate as this is the standard value published in Italian guidelines, and discounting is applied over the 6 years of study duration, as again, this is the maximum treatment duration allowed. So next we're going to talk about the assumptions.
Hey guys, Dave here. I'm going to talk a little bit about assumptions. Some of the assumptions pertain to the population. The most significant is that they assume that the BLISS trial cohort is similar or equivalent to Italy. So this is a pretty big assumption because those populations are probably not equivalent at least from a socio-racial standpoint. We talked a little bit about the currency and the treatment duration. Those are also assumptions we should consider. So for all the costs, it's basically assumed that their models were appropriate, when in fact their models were based on data from 3 different resources. One was the BLISS trial data, and the other was that the Johns Hopkins cohort was used to create a model to model disease activity. So these populations don't exactly line up, and those are pretty big assumptions. So you can see here that these 3 different colors of data were basically modeled using 3 different methods. So you have to assume those are all based on assumptions as well. Indirect costs is assumed to be calculated using the human capital method. That's probably appropriate. And overall, many assumptions are made. Most of those assumptions are stated. One assumption that is not stated are the discrepancies between the populations used to generate their predictive models. Sensitivity analysis were conducted. They evaluated several different situations. They also evaluated cost efficacy on a range of willingness to pay. So here you can see that there are several different cases that are considered. One case includes indirect costs. Another case excludes wasted product. I don't know why they would do that, because usually product is wasted. And then they assume a treatment duration of 10 years and decreasing efficacy over time. And you can see that there are differences here. Another way is they changed up the base assumptions in the population. And you can see that the main variable here is the treatment effect of Belimumab in determining cost effectiveness. Limitations were addressed. They recognized that their data was based on reference data and models. Further studies will need to be conducted, so post-marketing trials will help us determine more about Belimumab. And some unaddressed were the discrepancies between the population and rare side effects that might not have been detected by the BLISS trial. Here you can see significant differences between the Johns Hopkins cohort, which is used to model disease activity. They only had 140 enrollees who were not African American or Caucasian, whereas the BLISS demographic was mostly not African American or Caucasian. And now we'll talk a little bit about generalizations.
So overall, not many generalizations are made in the study. However, we would not be able to generalize cost results to other countries since the study is specific to Italy and they use specific tariffs and the patient access scheme that are specific to that country. And so also we may not be able to generalize results to patients with a more mild or moderate disease state, since in this study they're using a model with high disease activity. And as Dave kind of went over, the model may not be fully representative of an Italian lupus patient population, since the data is coming from the BLISS trial and Johns Hopkins models. So, although the authors used the best data that was available, many assumptions were made which could impact the results and could bias the results. Additionally, although GSK was not involved in the analysis of the data, they did fund the study and they paid salary to some of the authors. And GSK is the manufacturer of Belimumab, so that could bias results. Ultimately, though, the authors did a good job of limiting bias in the presentation of their final results. The use of a sensitivity analysis shows thorough and robust examination of the data, and the results do hold depending on the willingness to pay threshold set. So that demonstrates Belimumab is cost effective within an acceptable threshold given the low prevalence of the disease. So overall, it is likely that Italy would be able to provide Belimumab coverage to high risk or high disease activity lupus patients as a result. And here are our citations. Thank you for listening.